Good morning, good afternoon, and good evening, everyone, from wherever in the world you may be joining us today. My name is Francesco Del Carpio, and I am the CFAL York Operations Coordinator. I would like to officially open the 10th session of the Emerging and Systemic Risks monthly lecture series co-organized by YEmerge and CFAL York with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tkaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to our webinar. And with that, I would like to pass the floor to Dr. John Hong Wu from YEmerge to introduce our moderator.
Thank you, Francisco. Good day, Professor Harris Ali, good Professor Carrie Wu, and hello to everyone. I'm Jian Hong Wu, the director of the YEmerge, the York Emergency Mitigation, Engagement, Response, and Governance Institute. I'm very pleased that YEmerge is organizing this monthly lecture series on emerging and systemic risks in collaboration with the CFAL York and the Disaster and Health Emergency Urban Systemic Risk Transformation Research Cluster, or DOSA. YEmerging is a pan-university research center that is created to build on York's exceptional expertise to develop, grow, and sustain transformative and multidisciplinary research and training in transformative disaster risk reduction, emergency preparedness, response, and recovery. The DOSA cluster is funded by York University's Vice President Research and Innovation Office, and the cluster is comprised of 7 thematic subclusters. The clusters is co-led by Professor Afshan Zara from our Lassonde School of Engineering. The choices of the issues and the speakers of this lecture series reflect this thematic area as well. CFAL York is part of a Unitel global network of training centers for knowledge sharing, training, and capacity building for leaders, local authority, and civic society. Established in 2020, it's a partnership between Unitel, York University, and the York region, CFAL York, and the leadership Professor Ali Ashgari from our Faculty of Professional Liberal Studies, Arts and Professional Studies, is working closely with YEmerge to expand our experience and network globally. And this coordination of this monthly series is part of this joint effort. So with that, I would like to take an opportunity to introduce and thank our moderator, Professor Carrie Wu. Carrie Wu received his PhD from UBC and is currently assistant professor of sociology at York University. His research focuses on political culture, race and ethnicity, and health inequality. He has published intensively on these topics and often share his research with the public while national and international media. He's currently working on a 5-year larger Shark Inside Grant funded research project that is to develop a political sociology of health to study social and political trust is essential determinants of health. So I will thank you very much, Carrie, for moderating this session. So pass the floor to you, Carrie.
Thank you, Jian Hong, for kind introduction. Hello, everyone. Thank you for joining us today. So now I would like to introduce my colleague, Dr. Harris Ali. Dr. Ali is a sociologist at York University from the same department. He teaches courses in environmental studies, disasters, social theory, and environmental health. His studies focus on the social, political, and environmental dimension of disease outbreak and environmental disasters. He has conducted many studies on different types of infectious disease outbreaks in various parts of the world, including E. coli in Walkerton, Ontario, tuberculosis among the homeless people in Toronto, in the city, community-based responses in Ebola in Liberia, Sierra Leone, and the Democratic Republic of the Congo. Alongside his long-time research colleague at the Dadala Institute faculty fellow, Roger Kev, Professor Ali completed a comprehensive study of the 2000 outbreak of SARS in Singapore, Toronto, and Hong Kong. This culminated in an added volume on SARS, networked disease, emerging infections in the global city, which was recognized by the Global and the Mail as one of the top 10 books that offer lessons from past pandemics. Currently, he is a co-PI with Fuyuki Kurosawa, also from Sociology, on a CIHR funded research that involves big data analysis and AI to really understand the role of social media in framing and countering anti-Asian racism during the pandemic responses. Welcome, Haris Ali. And what we're gonna do is Dr. Ali will give about 35 minutes research presentation, and then we will have like about 15 minutes for Q&A. And we can, if you have questions, you want to speak up, raise your hand. We can unmute you. You can talk, or if you choose to write your question, you can also just write down your question in the chat box, and I will read your question. Okay, Harris.
Thank you, Carrie. And also thank you to Ali Askari and Professor Yanhong Wu for the invitation to speak today. I put on the first screen. Are you able to see this slide? Yes?
Yes.
Okay. So today I'll be talking about some research that my colleague and friend Roger Kyle and Creighton Connolly have done on the spread of infectious diseases in cities. And this is written up in a book called Pandemic Urbanism, Infectious Diseases on a Planet of Cities. Okay. So the overall research question for this book is basically are these ones. How does extended urbanization influence the way infectious diseases emerge, spread, and are contained, including the social, cultural, political, and economic factors involved? So it's a very broad approach. What is the social spatial logic of the urban and extended urban environments, and how do these influence the response to epidemics? And I'll be talking about this, and it will become clearer as we go on what is meant by extended urban environments. And in particular, how do contemporary urbanizing processes result in an uneven distribution of risk? And what implications does this have for the exacerbation of social inequalities during the COVID-19 pandemic? So we look quite a bit at inequality in the pandemic response, okay, and in the impacts of the pandemic. Now, the second part of the book looks at how infectious diseases, especially COVID-19, transformed or could potentially transform in the future urban life, urban politics, and urban culture. And really, this is an area that Roger and Creighton focus on, so I won't be going into that in too much detail here. Okay. Now, to guide our overall discussion of the social spatial logic involved, we adopt the perspectives of what's called the epidemiological triad and microbial traffic. And we combine these perspectives into what is called, we refer to as the landscape political ecology of disease perspective. And then we apply that to 3 case study situations, so SARS in 2003, Ebola in West Africa, and COVID-19 most recently. Okay, so I had mentioned this epidemiological triangle, and this is actually quite an important idea for our book and study. What we're talking about here is that, researchers have found that for the emergence of any disease outbreak, three sort of factors and conditions have to be in place. The first is the disease agent, that which causes the disease, like the pathogen or virus, bacteria, parasite, whatever. And then you need a host, which allows the agent, the viral agent, to reproduce, like the human host or the animal host, right? And then you need a conducive environment that allows the agent and the host to connect. And all these three sort of conditions have to be in place. Now, many times the environment is defined as the biophysical environment, that the weather conditions or the climate conditions, temperature, and so on have to be right for the disease agent or virus to survive and get to the host, right? But we extend this idea of environment to consider the social environment as well, right? Including the political environment. So, for example, you can take the case of tuberculosis, caused by a bacteria and the human host. And you can talk about how, the conditions, the biophysical environmental conditions for tuberculosis outbreaks are crowded conditions with poor ventilation, right? But the political environment, let's say, is that you're looking at homeless shelters in Toronto, and that the political environment is such that you don't invest in homeless shelters so that they become overcrowded, so that they become dilapidated, so that the beds are very close to each other, so that there's poor ventilations. So the political and social environment also contributes to the disease outbreak. And this is the sort of approach that we take. Right. Now, the thing is, there has been a lot of discussion about sort of flattening the curve, right, during the COVID-19 outbreak, and about implementing social distancing measures, protective measures like washing your hands and wearing a mask and so on. And the idea was that so that the number of cases would not exceed the healthcare capacity. So here you have, without protective measures, the healthcare capacity is exceeded. With protective measures, it's not exceeded. But the point of these protective measures is, in fact, they break the various connections between agent, host, and environment. So you wash your hands, you change, the environment. And so when you wash your hand, the agent and the host are not able to connect with each other, right? The virus is not able to get into the body. Right, you leave hand sanitizers at the front of all the stores. You change the environment as such. Again, you're breaking the connections between agent, environment, and host in effect. So this is quite a powerful explanatory model here, this epidemiological triangle. Okay, so we also connect it with this idea of microbial traffic. And this refers to the mechanisms involved in cross-species transfer, how the virus goes from one species to another and then to the human being, how the virus diffuses through spatial diffusion, what causes through environmental pressures, the evolution of the pathogen. So you have different strains coming about. Use of antibiotic resistance is another example of pathogenic evolution, and environmental changes which may induce changes in the virus. These are sort of aspects of microbial traffic as well. Okay, and most importantly, changes in the human environment relationship. And as we said, this includes the social, political, and economic environment as well. So these are all dimensions of microbial traffic that we also consider. Now, the context of our study is, look, in an earlier period of time, U.S. Surgeon General famously in 1967 had this quote: "Time to close the book on infectious diseases and to shift all national attention to chronic diseases such as cardiovascular disease, cancer, diabetes, and so on." So the argument was that, the society at the time was going to enter an epidemiological transition, that infectious diseases were thought of as something as the past, and that the developing world wouldn't have to deal with them either once they became more developed, and infectious diseases was something that we didn't have to worry about. But you can see 20 years after that statement, there was a whole flurry of new infectious diseases that were coming out, right? And you know many of them: HIV/AIDS, hantavirus, pulmonary syndrome, West Nile virus, E. coli 015787, mad cow disease, hoof and mouth disease, swine flu, different forms of avian flu, Middle Eastern respiratory syndrome, Zika virus, and of course, COVID-19, SARS. So the list goes on and on and on. So there was a sudden onslaught of diseases, right? And I can't get into the reasons for that, but the main sort of gist of why these have come out is the changes between human beings and the environment, and particularly those that are brought on by globalization. And this is cartoons that were put up like 20 years ago during SARS, right? You have this kid dressed up, ready to go to school in all this protective gear. And this was done in a mocking kind of way in 2003 during SARS. But this is what happens in COVID. People had to wear protective gear to go to school, all right? So you have these new and emerging diseases come about, right? And academically, technically, these are defined as diseases whose incidence in humans has increased dramatically over the last 2 decades. Newly appearing infectious diseases or reappearing ones like tuberculosis, and multi-drug resistant bacteria, and disease spreading to new geographic areas, right? So COVID-19 is one of them. So the first case study that we looked at way back in 2003 was the spread of the first coronavirus, SARS, through the global cities network, right? So this was in a sense one of the first sort of worldwide spreads of diseases, okay? And it spread through what is referred to as the global cities network. Saskia Sassen, a sociologist, defines like global cities as those sort of large cities that serve as the command and control centers of the global economy. Okay, so that the globalized economy couldn't function except for these major cities that are connected to each other, and connected to each other how? Through the flow of capital, through the flow of labor, through the flow of information. Okay, but as the 2003 SARS outbreak showed, it's not only these types of connections, but connections between viruses. So, we had done a study of how the cities of Hong Kong, Singapore, and Toronto are connected, and what that meant for disease transmission or spread, okay, or the microbial traffic, to use the term that we introduced before. Now, one of the things that came out from that research is how, cities, unlike in the olden days where you had city-states that were walled off for each other, city-states are now connected with each other almost in a 24/7 fashion through all these flows that are coming in and out. Okay, so it's much more permeable, these cities. And at least we can talk about that at a conceptual level. Now, the other aspects of cities that's important to consider in disease transmission is the infrastructure, right? And this is the case of Amoy Gardens, okay, where there's transmission of the SARS coronavirus from one apartment unit to the one below it, to the one below it, to the one below it in a vertical fashion. And the reason for that is the infrastructure is an infrastructure reason, okay? These apartment units are attached to each other through this vertical drainage pipe, right? And what was happening is that dirty water. There was one person a patient who had SARS, and it was shed through the diarrhea and dirty water. And this was sort of put into this down pipe. And so the water went down this pipe, and it spread to other units below. The thing is, this U-shaped pipe is supposed to contain water, so that there's a disconnect between the apartment above and the apartment that you're dealing with. This is a sort of a trap here. But this U-shaped pipe was not filled with water, and it allowed the bacteria to connect up, or the virus to connect up from one floor to another, right? So cities themselves and their infrastructure have important implications for the spread of disease. Same with Legionnaire's disease, right? And the spread of that through the hotel heating and ventilation and the air conditioning system, right? So we look in this book at infrastructure as an important component of disease spread too. Now, the spread of SARS in the global city network that we talked about highlights how infrastructural connectivity, including the network of airports, the exclusive elite spaces, the quarters where newcomers settle, whose precarious and often racialized workforce supported the global city economy. Because, you know, on the one hand, these global cities are some of the richest cities in the world, but who does most of the work in maintaining the global city? Often it's a racialized workforce, a migrant workforce sometimes, you know, to maintain the sort of luxury lifestyle of the elites, right? So there's a relationship between the elite people and the working class people and this sort of stuff that's also implicated in the spread of the disease. And it's also the case with Ebola, as we'll talk about later, okay? So we discussed that, you know, the spread of the disease in global cities and some of the implications. And, you know, in hindsight, we can say that the SARS outbreak in 2003 that we studied was really a test run for the COVID-19 pandemic in the response to it almost 20 years later. Now, moving from the sort of most sort of advanced and almost sort of luxurious types of city in the global north, in the global cities network, we can look at sort of the networks that were involved in the spread of another virus, this time the Ebola virus in West Africa and also in East Africa. And, you know, Roger and I have done a lot of work on the spread of Ebola in West Africa and have done field work in the countries there. Okay, and this is 2014 and 2016. And, you know, previous to the 2014, 2016 outbreaks of Ebola, most of the, if not all of the outbreaks of Ebola were limited to rural areas, okay? And, you know, there was a reason for that because, you know, sometimes the number of hosts available for the virus to take hold of was very limited, right? And so basically, you know, not to use a nice expression, the disease outbreak would burn itself out. Okay, because there were simply no more hosts for the virus to jump into. And so these isolated rural villages would almost, in a sense, naturally contain the spread of the disease. Okay, but something changed with 2014, 2016. The Ebola virus was able to penetrate very large cities, particularly the capital cities, you know, like Freetown in Sierra Leone, or Monrovia in Liberia, and it took hold in big cities. So the question is, why? Why did the disease go from being a rural disease to basically an urban disease? Okay. And, you know, we explore and investigate the reasons into this. You know, Ebola is a disease that, you know, some people hypothesize has become more prevalent because of the cutting down of trees, and this has led to more forest edge areas where Ebola is able to survive and proliferate, and more human beings come in touch with the Ebola virus, especially in informal settlements near the forest edge. Okay. So this is a change in the relationship between the human and the environment that I was alluding to before. But more than that, you know, there's a lot of influence about how global South cities have formed. And you cannot look at how global South cities have formed without looking at colonialism and the history of the legacy of colonialism on the cities in Africa. And, you know, part of this legacy of colonialism is little to no investment in the network infrastructure in informal settlements. And as you know, these, you know, as they used to be called slums areas, they don't have sewage treatment, water provision, electricity grid. And all these further exacerbate the spread of the disease in these areas. Okay. Now, what's notable and sort of a positive development is, despite the formidable challenges of mounting Ebola response that was effective, there was in fact an effective response to Ebola virus disease in West Africa, and it was based on the mobilization of community members. Okay, the social networks that were already in place in the villages and so on. Okay. Now, one of the things that we can talk about, though, is to compare and contrast the spread of COVID-19 with Ebola. Okay, you see, one of the things was I think this is an important point. Like, this is Syncor in Monrovia as an example, okay? That, you know, when travelers come from the global north, the hotels are in this area, right? But then there's another area of Monrovia, which is called West Point, which is on the ocean. And it's an informal settlement, one of the largest in Africa, as you can see here. Now, if you look at this on the left, the Syncor area, the more affluent area, you know, a lot of work is done by people who live in the informal settlements. So people from the informal settlements come to this area where they do work in gardening, or they do transportation of the people, work as nannies, you know, work as security, and so on and so forth, right? And they do their work in this sort of richer part of the city, and then they go back to their informal settlement. Now, this migration of people from the informal settlement to the rich area and back is very important, as is the travel patterns of the rich people. You see, it is the rich people who go into the airplanes on business travel to conferences and so on and so forth. And COVID-19 is a disease that spread in that way internationally. So many of the elites in the society would go on their travels, and they would bring back the disease with them. They would expose the workers, who would then go back to the informal settlement, okay? And then the disease would spread amongst the informal settlement, okay? And that was the direction of the spread of COVID, from the sort of basically rich people to the poorer people. But Ebola, the spread was different, because Ebola originally started as a rural disease, you know, in Africa, and as of course in many parts of the world, people have relatives who live in rural areas, other relatives who live in city, and of course you go and visit them for weddings and to stay over and to do work for a while in the city, then go back to the rural area. There's all sorts of social connections between the rural area and the urban area. So sometimes people in the rural area would be exposed to the Ebola. They would come and live with relatives, or come for a wedding or what have you, and live in the informal settlement for an area where exposure to of the Ebola virus would spread amongst those living in the informal settlement. These people would then go to the richer areas, and the disease would spread that way. So it's interesting to note how the disease of spread in that way. Okay. Now, the other thing that we talk about in this book is about what's called extended urbanization. Okay. And these are sort of the areas that are outside of the city, what are called in the periphery of the city. Okay. Look, this is a schematic with this center being the city, you know. And sometimes people have referred to the city as an entropic black hole. What does that mean? You know, those who have science background, you know, understand that entropy means disorder, right? And by the second law of thermodynamics, all natural processes go to increasing disorder. But here's the thing. Resources, raw materials, in a sense, are very ordered material. That's why they're valuable to human beings. Things like fossil fuel, things like wood, you know, they're taken into the city and they're burned or whatever in order to get energy. And then there's a waste product, ash, carbon dioxide, and that waste product is disordered. It is entropy. And so you go from a situation of ordered materials coming into the city, then disordered, being dumped outside of the city. From outside of the city comes in ordered stuff, then returning to the outside of the city is disordered stuff. This is why they refer to the city as an entropic black hole. But much of urban analysis looks at this core area, what's going on in the city. But what's going on in the city cannot exist with what's going on outside the city. Okay, and this is our emphasis on what's going on outside the city, because if you look at what's outside the city, and remember, the city couldn't exist without what is going on the outside of the city. You know, typically these peripheral areas that are outside of the city, which are often ignored, they tend to be associated with residential suburbs situated at the edge of major metropolitan areas. They include peripheral spaces adopted for a variety of other usages: agriculture, factories, warehouses, meatpacking facilities, landfills, quarries, airports, water treatment facilities, oil fields, recreational cottages, First Nations reserves, and of course, informal settlements. right? These are all on the outskirts of the city, right? And you know that, right? You see that, right? The airports are on the outside of the city, some oil fields, quarries, right? Factories, right? Some residential areas, increasingly, where the people work, right? And also what are outside of the city are where the people live, like the informal settlements we talked about, but also where the migrant workers work and the First Nations reserves are. And here's a sign at the outside of one First Nations. Attention, the community is requesting that only local traffic and persons conducting business on behalf of this community go past this point. This is for the protection of the community concerning COVID-19. Thank you for your cooperation. So this border checkpoint was established outside in a reserve on the peripheral of a city, right? And so, the peripheral of the city is also where people work. But again, these kind of areas are often ignored in analysis. But COVID-19 reveals that these sorts of outside the city areas are very important, because here is a map, for example, of COVID cases. And you can see the highest number of cases of COVID are not in the downtown area, in the city core, in the metropolitan area, but in the outskirts, on the peripheral of the city, in the suburbs of the city, like Mississauga, Brampton, Caledon. This is Peel County, right? And you can see in particular, this has the highest highest amount of COVID is in this suburb and outside the city area, L6P area code, right? And so the question is why, right? And this has a lot to do with inequality too. Certain of these areas, if you look at the areas of where you have COVID, right? These are here communities with the 5 lowest rates of infection. Okay, so the beaches, East End, Danforth, Lawrence Park, Yonge and Eglinton. I'm sure you know many of these areas, but these have the lowest amount of COVID. And look at the percentage of Black residents or residents living in poverty. 2% Black, 4% Black, 1% Black, 6% Black, 2% Black. Now look at the communities with the top highest rates of infection. Okay, look at the percentage Black: 11, 33, 24, 32, 19, in stark contrast to the low percentages here. And this is the inequality in the spread of disease that we're talking about, that I originally raised, right? And these areas where there's high COVID rates are on the outskirts from the downtown area, like where our university is, right? Black Creek, York University. These have higher rates of COVID. This is why it's more along the x-axis, but higher rate of Black population. This is why it's higher on the vertical axis, right? So we go into that. Now we can also look at what's going on in Brampton, as an example of what's going on at the periphery, those areas outside of the city. So here you have Maple Lodge Farms, meat processing, slaughterhouse, and there was an outbreak there. You had outbreaks amongst limousine drivers at Toronto Pearson Airport, it's also located outside of the city. One of the things in the L6P Brampton area is that you have a lot of industry being set up because of its proximity to the major 400 series highways, to the airport, and a lot of available land, right? So you had a lot of people working in the industries in Brampton and in the trucking industry and so on, and they were particularly vulnerable to the disease. In fact, there's a lot of Amazon fulfillment centers in that area because the land is available there, and there was outbreaks in these Amazon facilities too. So it is not surprising that the L6P area located outside the core of Toronto had high outbreaks of COVID-19. This is what we were talking about in our book. Now, despite that, and similar to the case of Ebola in West Africa, successful campaigns were made to combat not EVD, not Ebola, but in this case, COVID in Peel. And this was done, again, through much greater community involvement, okay? And vaccination programs, mobile vaccination clinics. This is right near my house that I took this picture because I live in Mississauga and was raised here as well. So you can see this is an example of a mobile clinic. So concluding remarks. the complexity of disease spread, okay, under the intensified conditions that cities face under conditions of globalization requires new and innovative approaches that simultaneously consider both the social and biophysical dimensions of epidemics, right? I mean, this is how we approach the epidemiological triangle in microbial traffic, right? Such considerations must be considered and incorporated if effective epidemic response measures are to be designed. Okay, this is why, you know, you had effective community-based responses both in West Africa and also in Peel. In this light, especially those that take into account, when I say here, community-based involvement in various capacities are especially important. Okay, so there's a lot in this book, and I had to go over this quite quickly, but hopefully some of the issues that were raised in the presentation I can address through the questions. So thank you very much.
Thank you, Harris, for a wonderful presentation, a lot of rich data, field work, and then theoretically quite rich. So, okay, we will turn to audience. Any questions? This one, raise hand. Francesco, were you able to unmute? So they
Yep,
can
I've
ask?
given them permission to talk.
Great, yeah.
Thank you.
Murtaza, right? Can ask
Yeah.
you a question, yeah.
Okay, thank you for your presentation. That was fantastic for me because my background is economics, and from point of the socioeconomic, I look at this topic. My question is that did you test for the fixed effect and random effect of for the panel data, using the panel data?
Yeah, ours was not a quantitative study, and so we didn't have like data like that. It was qualitative research, so it's kind of like those sorts of things we didn't consider.
Okay, because you mentioned on the demographic variables and the poverty, this could be tested in the panel data models and control for the fixed and random effect model.
Yeah, no, that for me that was secondary data that I was using from Toronto Public Health.
Okay, thank you, appreciate it.
Thank you. Others, questions? You can raise your hand or you can write your question through the chat box. That's okay. Jianhong, right? Jianhong, go ahead. Yeah.
Yeah, so Rachel is also raised. Maybe Rachel should go first.
Yeah, okay. Rachel, please.
Oh, I see. So Rachel is a congratulations note.
Yeah.
Yeah. So my question to Harris is really what distinguish the COVID-19 from, for example, pandemic flu and from for example, Ebola in Africa. So what made really COVID-19 COVID-19?
Yeah, I mean, you know, this is the thing, like Ebola is you know, is an infectious disease, but you really have to be in close contact with the person. And the person is most infectious with COVID-19 when unfortunately they're near death. And this is why with COVID-19, a good amount was spread during the funeral services, you know, where the people were washing the body as part of the religious ritual, but also because of caregiving, right? That you become in close contact. And that's why, you know, a good number of women, more than men, were also affected because they were involved in caregiving as well. But this COVID-19 is a respiratory virus, right? And so the mechanism for spread is different, and it enables it to reach more greater people, right? And also, of course, the biological characteristics, the R naught and all that is different, because Ebola is a filovirus, right? And the COVID was a coronavirus, right? But also it was the coronavirus was, you know, with Ebola, it is in Africa, and you know, it is a poorer area of the world, and so you don't have as much of the population being, if I can use the word, jet setters, going on airplanes and such, right? And as I said, it was in a more rural area. But COVID-19 was different, because if you remember, the initial cases were amongst the more elite people, the, you know, the celebrities you would find, you know, royalty, politicians, like this sort of thing was happening, because it spread through, you know, people traveling around the world, right? So I think these sorts of characteristics are the main thing, but also, you know, the world has become much more connected than it was in the past, right? So the migration, not only of people, but of goods and things and of trade, has intensified too, right? So this increases the potential for the networked quality of life has increased. And once you have more network, you increase the number and density of conduits for disease transmission. Right? It's a very general answer I'm giving to John Hong, because I don't know the sort of technical aspects involved.
Right.
Right?
Thank you, Ali.
Yeah. This question is a fair question of why was it much worse in the poor? Because, yeah, once it spreads, you see, you're talking about the big leaps from one country to another, right? But once it becomes embedded and situated in a local context, it spreads amongst the local people. And this is why Ebola virus disease, once it came into the poor areas where the informal in the slum areas, informal settlement areas where there's high density of people, it spread quite quickly, right? It's not either it was a disease of the rich or disease of the poor. It's a mechanism of both.
Great, thank you, Harris. Next question is from Brady. Do you want to speak up, Brady? Or I can, okay, yeah, so the question is about perception of risk. So Harris, great presentation. Are you able to talk more about how people perceive risk in different places, rural, urban, and how that matters?
Yeah, I mean, and from nation to nation and culture to culture, it's a risk perception is very much in a sense culturally influenced or culturally informed, right? But having said that, there are many similarities. So back in you know, several years ago, before the pandemic, I studied the Ebola with Roger, and one of the things that came out was this stuff about how people were saying, rumors were going about that Ebola is not real, right? That Ebola was a fabrication of the government in order to get money into Africa, like money from the global north into Africa, right? Or that Ebola was actually something genetically engineered on purpose to decimate the Black population, right? So these sorts of rumors and conspiracy theory were present during Ebola, right? And this hindered the response in some ways, right? But is that too far from what was happening with COVID-19 and the social media, where misinformation, disinformation, conspiracy theories of all sorts, you know, saying that this is a genetically engineered virus, COVID, you know, it was something engineered to give the Chinese country greater power, and these sorts of conspiracy theories were also there, right? So risk perception it's an interesting thing, right? And it's something that is really being manipulated these days through the social media, and social media is now something that is international, right? All the kids, even in Africa, they have their mobile phones. They're on this thing all the time, right? Just as it is in the global north, right? So this influences risk perception greatly, right? And then that, in fact, impacts whether people take protective action or not. Because if you don't believe it to be real, you don't take the protective measures, right? So my greatest concern these days is this social media and how misinformation and disinformation can be spread, because social media, information on social media is unregulated. Previously, with regular media like newspapers and all that, the journalists and the editors were gatekeepers. They would make sure that valid information was published. But with social media, any knucklehead could put in misinformation and spread it around the world, right? This is of great concern to me because it affects risk perception, right?
Next question from Sanju. Sanju, do you want to speak up? Ask question directly? Okay, let me, so the question is about human mobility, asking COVID was more spread by, more elite folks with access to travel.
Initially,
why was it
yeah.
much worse in poor communities?
Yeah, no, I had addressed that that question rather. You see, initially the spread, the big jumps were through the elite people going from country to country. But once it became embedded in the locality, then it spread amongst the community. You have the community spread, right?
Great. Brady has a follow-up question asking, any recommendation on how academic instructors should combat social media concerns, the globalization of risk perception?
Yeah, this is a very difficult question. And the reason why it's very difficult is what I was alluding to before, the unregulated aspect of the social media, right? So certainly academics can put up their own, websites and this sort of thing, but does it become influential, right? And most of the time it doesn't. So how do you harness the potential of the social media in beneficial ways? Well, that if something trends or becomes viral, it has more influence, right? Can academics somehow develop that sort of potential to get their messages across? I don't know. It's a very difficult question. But I would ask the person who asked the question if they have any suggestions on that.
Right. Other questions? I have a kind of a question. So sociologists, when we think about, for example, racial concentration, population makeup, especially Harris, you showed us that how, for example, in the city, for each neighborhood, the percentage of Black population is highly associated with higher infections and deaths. So we often think from sociological perspective, often think about the mechanisms, inequality, or like racism, and then some of them, the access to hospitals, and also maybe vaccination rates, so some of those mechanisms. But you mentioned today is really, there's two things that quite interesting. One is infrastructure, right? So neighborhood level, those facilities, and then how that, so built environment, right? So from sociological perspective, we overlook that mechanism. And the second that you also mentioned about is about interrelationship between neighborhood, between poor neighborhood and rich neighborhood, the dynamics. Then you mentioned about urban and rural, how like resources going in and then the garbage coming out, and how that like the dynamic of neighborhood relationship, that two like central mechanism could help explain why, for example, poor people from poor neighborhoods suffer more from disease outbreak. So then have you also think about the interaction between those physical capital or social capital, those kind of like, we from sociological perspective, the social relationship we focus more, but from your talk, you really highlighted those two more like physical aspect of those inequality and how they interact. So it's quite interesting.
Yeah, and if I could add to what you're saying, Carrie, what you say is true, but to develop it further, look, I showed two pictures that were quite contrasting. I didn't get into one of the pictures. It was a certain neighborhood in Toronto, and it was all high-rise buildings, right? And that had a very high rate of COVID. But then I showed the Brampton, which is a very large homes, right? And these are very different types of physical dwellings, you know, these high-rise apartment versus this detached house. And yet both of those two areas, neighborhood, had high rate of COVID. So the question is why? I could put in a third picture of condominium towers, in various parts of Toronto, and they had very low COVID rates, right? So if you look at these high-rise buildings in the poorer areas, you have elevators that aren't working, for example, because people don't invest in that, right? And if you went to those areas during COVID, you would see that the elevator is broken down, and then people are forced to crowd into elevators to go back home and to go to work. And everyone's going to work at the same time because the people living in these crowded apartment buildings are essential workers, right? Now, if you go to the condo towers in the downtown, you basically had more affluent workers who could work at home and socially distanced. So if you went to the condo towers and into the elevator lobby, it was a ghost town. But if you went to these other areas, it was active and busy because these were essential workers who couldn't stay at home, right? So this is where the social component comes too, right? About the nature of work, precarious work, essential work, all this who is able to stay at home during the pandemic and who isn't, who has to go on public transit and who doesn't. In Brampton, one of the areas I'm talking about, they had to shut down a bus line, the bus line that was going to the Amazon fulfillment center, right? And you also see in Brampton, and you don't think of this, that because of all those facilities, the slaughterhouses and the warehouses and the factories, those public buses are very busy, right? Whereas in the downtown core, you don't see the similar thing, right? Yeah, so this idea about neighborhood composition, social inequality, the physical qualities are all, interrelated, right?
Thank you. Yeah, thank you. And then just responding to the first question about the survey longitudinal analysis, random fixed fact. So like I do a lot of kind of research, but it's very difficult for that kind of data to really provide detailed analysis like yours, Harris. Really rich field work, rich data collection, and how a case study comparing different neighborhood is almost like a social experiment.
Yeah.
Okay, so next, Brady has comments to the photo up about how to better combat social media in globalization risk. So mentioned about that ways to teach nuance in a way that is easily understandable to the normal person. And Dr. Ascari published in the newspaper The Conversation. So they say efforts like this can be the step in the right direction. Ali, Ascari, do you have anything to add to this point?
Thank you very much. This was a really great presentation and talk, Iris. Appreciate that. Well, I have maybe a question, and perhaps that is more in line of what we can do for the future. And that is basically learning from what has happened, looking into the future. What are your key advice or advices for urban politicians and urban planners overall in moving forward with what we experience? with the past cases that you examined, and also in particular what we faced during COVID situation. I'm sure there are a lot, but if you can highlight some of those that you recommend most, then that would be really great. Thank you.
Yeah, like the main thing is, and as disaster researchers, this is a similar sort of approach, is to have much more community involvement, right? It can't be just a top-down approach, right? Because the top-down approach is sometimes the people who are making the decisions, they're making decisions without understanding locally what is happening, right? It's like the generals having tea in the away from the battlefield while the privates are fighting the war and the battles, and they don't know what's going on in the field, yet they're making decisions, right? And so this is a more general thing about command and control and disaster management, right? There needs to be a mechanism. I mean, I'm not saying abandon command and control, but I'm saying that there needs to be a mechanism where the bottom can also feed up to the top, right? So that the direction goes that way too. So during the pandemic, why the responses that were effective also with Ebola was that you consult with the local community things, give them a bit of well, sometimes even a lot of autonomy to self-organize, right? And let them carry out the work too, because they're the people most familiar with what's going on. They're the people who know what the rumors are. They're the people who know, what should be done to counter the rumors, right? So this community involvement in the disaster response or the pandemic response, I think, needs to be institutionalized in more formal ways, and giving sort of greater autonomy to those at the bottom. I think that's the greatest take-home lesson from all this, to be honest. Right?
Great. So the very related question from Judy. So Harris talked about like we need community involvement, institutionalized. So question from Judy is that how can we teach in classes, curriculums, like promoting people's participation in, for example, the engagement or mitigating the spread of disease?
Yeah, the only way, well, one of the ways that it can be done is those sort of non-governmental organizations who would be tapped upon to do such things. They need to come into the classroom and they need to say that these are the challenges we faced on the ground. And also, in the case of the pandemic, many of the people in Peel are South Asian, and so are the doctors, right? And so their training sessions had to be made with the family physicians about how to communicate with the people and this sort of thing, right? So it becomes now a matter of how to facilitate communication with people like physicians, family physicians, and also the non-governmental organizations. In other words, to increase collaborative connections, right?
Great. We are running out of time, but we have a final question about where do we get this book, and whether we can find you to sign this book if we get the book.
Yeah, I through the normal channels, I guess.
From Rachel, the
Amazon
question
or
from
whatever.
Rachel.
Maybe it's in the bookstore. I don't know. Yeah,
It's here. So the York Bookstore has it displayed in most prominent place.
Okay. Okay.
Great. Yeah. Okay. Thank you, Harris. Thank you, everyone, for joining us today. And I'm sure you'll be able to find Harris in online. And if you have further questions, please reach out. And back to you, Ali. Asker, Doctor.
Thank you very much, everybody, for joining, and also again, thank you, Professor Ali and John Argu, and also Carrie for moderating this session. And thank you all for attending. We will be continuing this series on same time next month with another topic. Looking forward to your participation. And always, if any participant has any suggestion for topics to be covered, we welcome suggestions, ideas. You can email us and you can contribute to also. And if you have any topic to present yourself, please let us know. We are open to suggestions, ideas from everyone participating, everyone interested in this line of research and activities. Thank you so much, everybody.
Bye-bye. Thank you.